Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing nutrition in pediatrics. And the reason that we are discussing nutrition in pediatrics today is because the pediatric population is drastically different than the adult population whenever we are referring to nutrition. Pediatric population has its own set of indications for both enteral and parenteral nutrition, as well as its own dosing requirements for both parenteral and enteral nutrition, with many of the doses being much smaller than what you would see in adults. Though on a weight basis, they may be higher than what you might see in adults per kilo. And that's essentially the reason why we're talking about this population today, is because it's just so different than the adult population, as you'll see whenever we start comparing the nutritional requirements. So our objectives today will be to identify indications for parenteral and enteral nutrition in the pediatric population, to calculate macronutrient, micronutrient, and fluid requirements in pediatric patients, and to discuss nutritional considerations of pediatric patients. Whenever we refer to the macronutrient and micronutrient requirements of patients, we're more so referring to trends in pediatric patients. So you won't necessarily need to know all of the actual weight-based numbers for macronutrients and micronutrients, but there will be a method that we'll discuss for fluid requirements that you will need to know. So just some definitions to start us off in regards to keeping everything consistent. Anytime that we discuss these terms, these are essentially the types of patients that we're referring to within the pediatric population. So a neonate is a patient who is less than 1 month old. An infant is someone who is less than 1 year old. A child is 1 to 10 years old. And an adolescent is going to be, for our purposes, 11 to 18 years old. Anybody who we consider above 18 years old, we will consider an adult for our purposes for this talk. In reference to evaluating pediatric patients from basically birth until adolescence, you can essentially evaluate the growth of a pediatric patient by comparing that patient's growth to the rest of the pediatric population who is the same age. And this is done with pediatric growth charts. So for those patients who are less than 2, they actually should be evaluated using the WHO International Growth Standards for weight for length, and head circumference. And this similar scaling is found on the CDC website with the link that you see here. And those who are 2 to 20 years old, they should also be evaluated utilizing the CDC growth reference charts, which you can see at the same link here. Give you a little bit of an example of what these charts look like. This is an example for females who are 2 to 20 years old in reference to stature for age and weight for age percentiles. So you see a whole bunch of different things on this actual chart here. You see basically here weight and stature here on the y-axis on the left side, and then weight and stature here on the y-axis on the right side. And then on the x-axis, you'll see age. Now, in reference to actually where patients fall, patients will fall somewhere on what we call a percentile. So this percentile is basically where you are at in comparison to the rest of the population. So if you are at, for example, the 75th percentile in regards to weight or in terms of stature, that means that you are the same, or basically at the level or the 75th percentile level compared to the rest of the population. So basically that means that you are potentially, if you're referring to weight, at or above the weight of 75% of the other patients who are in your particular age. The same can be said for stature up here, where you see that the stature numbers are much narrower in terms of the percentiles. We'll refer to these charts more whenever we actually work through a case in class. In regards to pediatric patients, it's very important to understand how feeding eventually develops in these pediatric patients. So obviously from for patients who are just born to 4 months, they're going to be basically just bottle feeding or breastfeeding, depending on the parent's preference. And usually they use a reflexive suckling pattern whenever this happens. So essentially, they're more or less using reflexes to basically suck on either the nipple of the bottle or the breast. In regards to patients who are newborns, they tend to feed on average every 1.5 to 2 hours, so they need nutrition constantly. In patients who are ages 1 to 4 months, they feed an average of every 2 to 3 hours. So as patients get older, their feeding interval changes to where it is increased. For patients who are age 6 to 9 months, they also continue bottle or breastfeeding on an average of around 3.5 to every 4 hours. And at the ages of 6 to 9 months, that's where we actually get introduction of simple baby foods, with the conversion to essential soft mashed foods at 9 months. For patients who are 9 to 11 months, they continue bottle or breastfeeding on an average of every 4 to 6 hours. And at this point, they're starting to actually learn different movements of their mouth in terms of munching and chewing around the age of 9 months. With introduction of foods that easily dissolve at 10 months and introduction of easily chewable foods at 11 months. So as they learn their mastication techniques or chewing techniques, basically patients are able to easily chew foods a little bit better, especially as they progress in age. From age 11 to 12 months, they continue bottle or breastfeeding, but now they're only doing so every 6 to 8 hours. They may have introduction of soft single ingredient foods like avocado, or multiple ingredient foods at 12 months like macaroni and cheese, for example. And their chewing pattern essentially is still advancing more to a circular pattern at this point, with side-to-side tongue movements, which essentially is starting to get more similar to what we see in adult patients. So in regards to feeding development, if feeding development doesn't work out for a patient for some reason, or if a patient is born where they're not able to feed properly, they may actually need enteral nutrition. And for enteral nutrition, some of the indications for enteral nutrition will actually be very similar to indications where we saw with the adult patients. So the first main category of enteral nutrition indications for pediatric patients is for inadequate oral intake. So that's basically one subset of those inadequate oral intake patients include patients who have increased nutrient needs. So patients who have cystic fibrosis, for example, who are very hypermetabolic. Those who have bronchopulmonary dysplasia, where essentially they may not be able to breathe properly due to some kind of malformation of the bronchopulmonary area. Patients with congenital heart disease, renal disease, infection, surgery, burn trauma, or just a failure to thrive, where they're not actually being able to thrive on their own. Maybe they might not have that suckling action that a normal neonate may have at the very beginning. And if they don't, then they're going to need to get their nutrition via some other route. Same rules basically go for enteral nutrition, in that they still need to have some kind of functional GI tract and be able to absorb to an extent. In regards to also inadequate oral intake, enteral nutrition may be needed for patients who have developmental delays. So, for example, that includes a preterm birth. So if you're not born at 40 weeks gestational age, you may need to be on enteral nutrition depending on tolerability. Patients who are intubated, basically the same indications for adults. Those who have neuromuscular disorders or neurological impairments may need enteral nutrition. If they have some kind of behavioral issue that prevents them from getting inadequate oral intake, such as feeding aversions, an unpalatable diet, or anorexia nervosa, or other feeding disorders, they may need enteral nutrition. Patients may also have anatomical issues that prevent them from getting regular oral nutrition via that typical suckling pattern. That can include cancerous burns and mucositis, or essentially inflammation of the mucal areas, congenital malformations. So if there is an area that is not fully developed, that prevents a patient from basically, sucking or suckling on that nipple, or in regards to even swallowing, that might be an indication for enteral nutrition. In patients that have tracheoesophageal fistulas, so basically, more or less, remember, a fistula is something that is a disconnection that will cause basically a little, or that basically where a little hole is contained where lots of output may come out. And again, oral intubation is another one listed under anatomical, and note that it's listed twice. Airway protection for anatomical reasons such as tracheoesophageal fistula, again, paralyzed vocal cords, or severe reflux. Again, for developmental delays where you have neurodevelopmental delays or cerebral palsy where patients still need airway protection, such as intubation, for example. If they're intubated, then they may be candidates for enteral nutrition, assuming that their GI tract is functional. You might also see some patients with potential malabsorptive indications. Now, even though these indications are malabsorptive in nature, that doesn't necessarily mean they're precluded from getting enteral nutrition. They still may get enteral nutrition if they can tolerate it. So these are basically short bowel syndrome, which we've talked about before, high output ostomy, so basically an ostomy that is putting out a lot of fluid, Crohn's disease, or pancreatic insufficiency. Now, flipping from enteral nutrition to parenteral nutrition. Remember, parenteral nutrition is when basically you cannot fully tolerate a regular oral diet via the GI tract, or any diet via the GI tract. That includes potentially enteral diet as well. So remember with PN that usually enteral nutrition has to not be able to be tolerated. Usually this is the case in premature pediatric patients, and this is usually required immediately upon birth because they may have low nutrient reserves, increased energy expenditure, GI tract immaturity because they weren't basically getting to full term, or increased risk for acute or chronic illness. You may also see some GI conditions, obviously, because it is parenteral nutrition. So you may see some congenital anomalies or abnormalities, some short-term GI disorders such as motility disorders, some small bowel obstructions that can result from a few different things such as volvulus, for example, or nausea and vomiting, necrotizing enterocolitis, and again, short bowel syndrome. But remember, with short bowel syndrome, that's a tolerability issue. If they can tolerate enteral nutrition, they should get enteral nutrition. For patients who are critically ill, parenteral nutrition may be indicated in those that have hemodynamic instability. So if the patient has hemodynamic instability, remember, essentially the same concept with adults as with our pediatric patients, the blood shunts away from the gut. And if the blood shunts away from your gut, then in that case, you may not be able to tolerate oral or enteral feedings very well. And that relates to enteral feeding intolerance. If the patient is not able to feed via the enteral route, they may be indicated for parenteral nutrition. And chyle leaks is another indication. And remember, chyle leaks are just essentially a leakage of chyle out into the non-lymphatic space. Typically, though, we usually do enteral nutrition for this first if patients can tolerate it and it doesn't leak out. You might also have some oncology indications for pediatric parenteral nutrition, such as graft versus host disease, radiation enteritis, which we've talked about with the adult patients, as well as cachexia. So basically with our pediatric patients, you see here that the indications for parental nutrition are a little bit more varied compared to our adult patients. We want to make sure that we can get as much nutrition into our patients as possible, particularly the pediatric patients, because essentially, remember, they're still growing. And they may have not even really, begun a significant part of their growth yet, especially with our preterm infants who may be, less than 1 kilogram big. For them to eventually mature and grow into healthy adults, they need aggressive nutrition at the early beginning stages of their life. In regards to macronutrient and protein requirements, all I want you to know from this slide here for protein requirements is that even though you see that the grams per kilo of protein per day for patients who start off much earlier on in life, such as very low birth weight or preterm or neonatal, these numbers are essentially much higher than what we would consider for most adults. But remember that a lot of these patients may only be particularly maybe within a few kilos, particularly whenever they're born. So just keep that in the back of your mind, though, that if you have a very low birth weight and you're 1 kilogram big, and you're getting essentially 3 to 4 grams per kilo per day, you might be only getting 3 to 4 grams per kilo per day total, or actually 3 to 4 grams total per day, because essentially you might only have a 1 kilogram patient here. So basically, as your patient matures and into adolescence, you start seeing that those protein ranges go from the much higher end of the grams per kilo per day range to the much lower part, to 0.8 to 1.5 grams per kilo. And eventually, whenever they become an adult, you might consider them 0.8 to 1.0. Here are some more macronutrient requirements. For protein, it's basically similar to the last slide with some slight alterations here toward the end. I don't usually want you to be focused on the specific numbers again. I just want you to be focused on the trends as they basically go from infancy to child to eventually an adolescent. So in terms of parental nutrition, your requirements will depend on whether you're preterm or term. And then for advancement purposes, you can advance by these amounts in the middle eventually to your goal. And you see that the goals are listed here and the units that are listed on the left side for the purposes of each age range. So all I want you to get from this is that there are different requirements for the preterm and term infants as well as neonates and children and adolescents. So it depends on your age. It depends on whether you're preterm or term. And once you basically classify your patient into preterm, term, and age, then that will determine what your requirements actually are. And you can see that as the patient ages, the requirements change pretty drastically. In regards to fluid requirements, there are many different methods in the pediatric population to determine fluid requirements for pediatric patients. The most common formula or method to use is the Holiday-Seeger formula or Holiday-Seeger method. And it's essentially broken down here below in the bolded numbers that you see here. So these numbers are bolded, so I would definitely know these numbers for your exam. In regards to patients who are less than or equal to 10 kilos, it's 100 mils per kilo. If they are greater than 10 kilos to less than or equal to 20 kilos, it's 1,000 mils plus 50 mils per kilo for every kilogram above 10 kilos. And then for patients who are above 20 kilos, it's 1,500 mils plus 20 mils per kilo for every kilogram above 20. So how does that little second part work out whenever you have 4 kilograms above a certain amount of kilograms. Well, let's say if you had a 15 kilogram patient, for example, you would basically use this middle formula here, and you would do 1,000 mils plus 50 milliliters per kilo for each kilogram over 10 kilos. So basically that's 5 kilos in a case of a 15 kilogram patient. So I would multiply basically this second part of the equation, the 50 mils per kilo, times 5. So 5 times 50, if you use order of operations, is 250 plus then 1,000. That would be 1,250 milliliters. This slide details electrolyte requirements for our preterm neonates, our infants, and children, as well as adolescents. You see here that the ranges are much higher in per kilogram dosing than compared to some of our adults. For example, in our adult patients for sodium and potassium, we typically recommend 1 to 2 milliequivalents per kilo. But in preterm neonates and infants and children, they need much higher milliequivalents per kilo. But remember, they are much smaller in weight, so this might not necessarily amount to necessarily the same dosing that you would see in adults. And you see basically the trends here as you basically go down and further to look at the other electrolytes. Again, acetate and chloride in your PN bag are used to maintain acid-base balance, just as with your adult patients. In regards to multivitamin requirements, all I want you to know from this slide is that depending on the patient's weight, that will actually dictate the dose of the parenteral multivitamin that they get. I don't want you to know specific dosing for these. It's just a reference for you, but just know that it is based on weight in this case. For trace element requirements, it's also really just dependent, again, on weight and age. So you see here with preterm neonates that are less than 3 kilograms, they basically get the requirements that are in this first column here. For term neonates, they will get the requirements that are here. And you see basically those requirements kind of more or less trickle down as we go down. There are some specialized nutrients that mostly just pediatric patients receive, particularly within their parenteral nutrition formulas. One of them is Lcysteine. And this is a conditionally essential amino acid for neonates and infants. The important thing about Lcysteine that you need to know is that it's used to reduce the pH of the PN formula to allow increases in calcium and phosphorus solubility, or calcium phosphate solubility. So basically what cysteine does is the amount of cysteine that you have in the bag will actually allow your calcium and phosphate to basically dissolve a little bit easier. So if you remember back to calcium and phosphate solubility whenever we initially talked about parenteral nutrition, we talked about the factors that basically affected solubility in parenteral nutrition bags. But the one criteria we did not mention was cysteine in parenteral nutrition bags for pediatric patients. And basically, the reason why we put Lcysteine in these bags is because these pediatric PN bags may be very, very small, depending on what the patient's fluid requirement actually is, depending on your holiday seeker formula. Whenever you are actually putting in larger amounts of calcium and phos compared to that small volume, you need to make sure it's as soluble as possible so it doesn't precipitate in that PN bag and then get delivered to your pediatric patient. In general, we usually give about 30 to 40 milligrams per gram of the Lcysteine per your pediatric amino acid. So for every gram of pediatric amino acid, we give about 30 to 40 milligrams of Lcysteine to make sure that that calcium and phosphate is soluble within the PN bag. Another thing that's given in pediatric PN bags is carnitine. And carnitine, if you remember back from biochemistry, is used to transport long-chain fatty acids into the mitochondria for energy production, also known as the carnitine shuttle. This can improve lipid tolerance, fatty acid oxidation, weight gain, and nitrogen balance. You see the dosing here for carnitine. For the dosing for carnitine, for infants, children, and neonates, you do not need to know the dosing. Just know that the dosing is different. Here is the reference for today's talk. And if you have any questions about nutrition and pediatrics, please feel free to let me know. Thank you and have a great day.